Welcome and thank you for joining us this evening. Tonight we'll be discussing the powerful results from the recent Evanthea randomized control trial. If you have questions this evening, please feel free to type them in the Q&A as we go along, and we'll do our best to answer everyone's question this evening. At Kemper Cognitive Wellness, it is our singular focus is brain health, and reversing the symptoms of cognitive decline is our number one passion and purpose. It is my pleasure to introduce to you this evening the lead investigator at the trial site in Rocky River and Kemper's Chief Scientific Wellness Officer, Dr. Nate Bergman. Dr. Bergman?
Yeah, thanks, Val. And we're very excited to have Dr. Dale Bredesen with us, and I'll introduce him for a second in a second to talk about the results of our Evanthea trial that we're just completing. But I would be remiss if I didn't first say thank you to all the people that were involved in the study. Our participants, many of whom are joining us tonight, our team here at Kemper, the Kemper site, Nikki Gould, Shelley Rosepaul, Allison Connors, Jackie Huron, and Nick Radka. We also need to say a big thank you to Diana Merriam and the Four Winds Foundation and the Kemper family for supporting this enormous undertaking. Dr. Dale Bredesen is an internationally recognized neurologist, and the reason probably so many of you are here tonight. He's got specialty expertise in mechanisms of Alzheimer's disease and other such diseases, neurodegenerative diseases. Before personalized precision medicine, Dale had made numerous original contributions to the medical and scientific community, and for the last 12 plus years, he's been one of the leading voices hypothesizing ways to reverse symptoms of cognitive decline. And it was Dr. Bredesen's hypothesis that we were testing in the Evanthea trial that we're going to talk about tonight. He's been a mentor and friend to me for about 11 years now. Dale, we're thrilled to have you with us tonight.
Great to be here. Thanks so much, Nate. And I was just actually talking to my wife when we met you, as you said, a little over a decade ago. And it's just to see where you've come and the great things you've done. Just wonderful for me to see. Thank you for the great work you've done and for so many people that you've helped.
Yeah, thank you. So thanks for saying that. Questions were submitted in advance by our team, a number of study participants and some current patients and members. But if we encourage you to be active in the Q&A. We'll get to as many questions as we can. We're going to do kind of some high-level stuff first, and then we'll get into some of the detailed questions. If your question's not there or you just think it won't be there, just please, I encourage you to just send the questions, and we'll manage that as we can. Dale, to start us off, can you just kind of give us a high level of what we tried to accomplish? Who are the sorts of people we're working here in the trial, and then to what, what kind of results do we get high level? And we can use some visuals if we need them.
Yeah, great point. And so, the highest level view here is we're trying to bring pathophysiology to public health. So we're trying to say, look, here's how we studied 30 years in the laboratory, published hundreds of papers looking at how does this actually work? Now, okay, what can we do about it? And as you know, the entire field of neurodegenerative disease, which has been arguably the area of greatest biomedical therapeutic failure, is slowly moving from pathology, oh, look, it's amyloid, it's tau, it's alpha-synuclein, to physiology. Why are these there? They are antimicrobial peptides. They function as prions, things like this. So we're starting to look at how do we test this idea of a precision medicine approach. We identify all of the drivers, and there are often, as you know, many, and then we address those different drivers for each person, and they will be different for each person. So we brought together, now this is 3 years ago, we brought together 6 different sites, including Kemper, of course, and we brought together 6 fantastic investigators like yourself, and with their whole teams. And it really does take an excellent team to include things like nutrition and things like that. And then we solicited people who are having cognitive decline and defined very clearly as MCI, mild cognitive impairment, or early dementia. And this was meant to line up with the drug trials. So very similar. Now, to be fair, this is still the 3rd and 4th phase. You go through an asymptomatic period, you go through SCI, then MCI, then dementia. So these are in that 3rd and early 4th stage as you're developing cognitive decline, though they had to have a MoCA score of 18 or above. Again, so that means mild cognitive impairment or early dementia. They had to have an AQ score greater than 4. So that means that their significant others noticed that they had problems. They had to have cognitive complaints. So there was a whole set of criteria, as you know very well. And then we look at those and look at evaluating what they are, and then looking at 9 months of personalized precision treatment of group one, group A, versus a group that had standard of care, basically, that which for MCI is very little, being told to do some exercise and quote eat right, and very little that's typically done for that. And then we looked at the end of those 9 months, as well as 3, 6, and 9 months. What happened to them cognitively, epigenetically, biochemically, imaging wise, on and on and on. So the data set is quite large to look at these people over time.
Dale, I'm going to share a couple things here. Just maybe we can run through a couple of things that will help people understand the results. Maybe we want to start with the forest plot and just kind of simplify the language here to understand what this means.
Yeah, this is a really good point, Nate. So I think this is actually the most important graph of the entire thing, although the graphs are quite striking, as you'll show here, with things like the memory change. But what this is doing, and this was calculated by the statistician, Dr. Stephen Ada, and what this is showing is the comparison of different trials. So when you calculate something which is called an effect size, how big was your effect that you had with your therapeutic approach versus everybody else's? It's a way to normalize so that you can literally compare all these different apples, basically. And so this gives you a way to do that. And as you can see here, the pointer one at the bottom here, which was the one from the Alzheimer's Association recently, which got a lot of press, has a very, very tiny impact. It's almost that vertical line means no impact whatsoever. So there was a tiny impact. It was about 14 times less than the Evanthea trial. Then you can see the next coming up is lecanemab, the drug that was considered, it was hailed as a quote breakthrough. It was 7 times less than the Evanthea trial for its effect. And what it does is it slows the decline, but it doesn't make you better. Then the next one coming up here is donanemab, which is also called Kisunla, which is from Lilly. And this one was 4 times less. So in other words, 300% less. The next one here is a personalized approach from Dr. Richard Isaacson, who's done wonderful work on prevention. And his trial, there was an effect here, even the people who had MCI, although not as much, but there was an effect there. And then you can see here, Dr. Dean Ornish had a fairly good effect with his lifestyle approach, but none of them even came close. So for example, Evanthea, the effect size was 90% greater than Dr. Dean Ornish's trial, just as an example. And the difference was everyone's taking a little bit different approach. Understandably, we need all these different approaches to get an idea what works the best. With Dr. Ornish's approach, they looked at a specific set of things and they didn't personalize it. So it was, you do this for your lifestyle. Whereas with Evanthea, we're looking at, are there mycotoxin exposures? Are there other toxin exposures? Are there specific infections we need to get at?
Dale, I want to, because I want to, if we could, can we hit the cognitive sort of the results first, and then everybody wants to hear you go into mechanisms and talk about all of the things that we tested. That would be amazing if we do that next. Can we just, at a high level, these are sort of the cognitive, you want to explain what we're seeing here? These are the NCI numbers.
Yeah, great point. So this is just going over the 9 months of the trial, and you can see here the group that was going to be treated actually started out a little bit lower than the group that happened. Now these are randomized, so it was just a random selection, but you can see that they actually started out a little bit lower.
So the treatment group is the broken line. The
broken line is the one that had the precision medicine approach. And you can see it's going up, up, up. They're getting better at 3 months, still better at 6 months, still better at 9 months. And I should add, we see people all the time who are still getting better, years later. They're still making advances. So that's great to see. Whereas you can see with the line that is unbroken, the solid line here, you're going downhill over time, just as we know people do. People untreated or standard of care treatment, they tend to go downhill. Now, the important question then is is this statistically significantly different, or is this just a random event? So you can see here in the upper right, it says p-value less than 0.001. What that means is there's less than 1 in 1,000 chance that this difference was just by chance, for no other reason. In other words, it means that that what we were doing actually works, and that's key.
Yeah. Okay. I mean, I think the rest of the results basically are more of the same. Based in almost every, people can just sort of see that the dotted line is a group that we intervened with, and in almost every, but not every, but almost every single category, there was a difference that was important in the group that we intervened on.
And I should say they were all statistically significant. So even processing speed, executive function, overall memory, all of these things were statistically significantly better when treated with this precision medicine protocol. And I should mention, of the 6 sites, we also looked at each site separately, and the Kemper site was one of the very best. It did very, very well. So congratulations to Nate and his whole team there.
Yes, it's a privilege to be part of a team. Like you said, that's probably the most important thing, is the team here. Okay, so now, all right, so people in general, we took people with a mild cognitive impairment, MCI, very, very early stages of dementia in a few cases, so minimal loss of independence. That's not everybody. That's not everybody that we see. That's not everybody that you see. But can you tell us a little bit about, okay, this is a personalized precision medicine trial. This wasn't just a lifestyle trial. Can you give us now, what did we test? How is this different than the Ornish trial? Like you started talking about toxins, infections, hormones. How many things did we test? You go back to those slides you do 10, 11 years ago where you had like 200 things on it. You remember, like the days where one slide, 200
So
things.
yeah, we spent many, many years in the lab looking at what are the actual molecular drivers. You're looking at APP and A beta and specific kinases and all these different molecules that interact with each other. And when you then take the 100,000-foot view, you step back and say, okay, this is all great to look at these little molecules, but what does it all mean? When you take a step back, the pattern you see is that this is literally like a switch. So you're literally switching, just as you switch from sleep to wakefulness, and each one is associated with different physiology. You also switch from a connection to protection, basically. You're switching from being able to make new memories, you're putting your resources into connectivity, learning new things. When you now have various insults, you are literally switching, and you can see it at every level, from the molecular species all the way up to the human being. You can see all these changes that are associated with going into this protective mode. And that's why you're making the amyloid that has been vilified in Alzheimer's disease. You're literally sensing these various things. So as you said, you're testing for the things that drive this, and the major drivers of cognitive decline are energetics. So are you getting enough sleep? Are you getting enough oxygenation, enough blood flow, enough mitochondrial function, all that. It's inflammation. So it's, do you have infections? And you guys tested beautifully for all sorts of viral infections, bacterial infections, spirochetal infections, changes in microbiome, all these sorts of things. And then, of course, it's toxicity. And those we break down into the big 3, the inorganics, things like air pollution. We have major problems out here in California with the California fires. It's an unfortunate source of air pollution. And of course, there's car-related air pollution. It's mercury. Then it's the organics. That's the second group. Things like toluene and benzene, and unfortunately, microplastics. And then the third group is the biotoxins, things like toxins from mold species, trichothecenes and ochratoxin A and things like that. So all of these things were tested for, including gut health, including oral health, the oral microbiome. All of these different things were looked at, including then imaging, even evaluating hearing, all these sorts of things that were critical. So we're basically working backwards from, now that we understand the disease better, what is it all about? What is it responding to? We can say, okay, here's what we have to evaluate, and here's what we have to do to optimize each of these things. And when we do that, it's 7 basics and 2 specifics, and that's the treatment portion.
So can you talk about the 7 basics and the 2 specifics on the treatment portion then?
Yeah. So now you have an idea for each person. Okay, here's what's caused. And when When talking to the students, I always say after they go over a patient, I say, okay, can you tell me why this person is developing Alzheimer's? And the first time they always say, well, what do you mean? He has Alzheimer's. We don't know why that is. But that's the whole point. You want to understand what's at the end of each person. You should say, this is why this person is failing in this synaptic network. Then to apply it, the 7 basics are diet, which is a plant-rich, mildly ketogenic diet, because that gives you optimal energetics, optimal blood flow, optimal detox, etc. Exercise, sleep, stress management, brain training, detox, and some targeted supplements. Those are the basics for everybody. Then the 2 specifics are if there are specific infections, they need to be treated. If you have herpes simplex, which is, by the way, one of the things that causes your brain to make amyloid, then you need to treat that with things like valacyclovir or other. And there are a number of ways to treat this. Are there other infections? Do you have a tick-borne illness? Things like that. So there are multiple of these that you need to treat. Those are specific. And then the other one is, as I mentioned earlier, the toxins. If you have exposure to various toxins, whether it's mercury, whether it's mycotoxins, you need to treat those things. So if you optimize those 7 basics and the 2 specifics, the vast majority of people get better.
Okay, so get better. The follow-up question is, well, how much better? Are there people that don't get better? I just want to make sure we're
Yeah.
transparent with people. Every single person's going to improve, and we've all seen
Yeah.
people that haven't improved. Sometimes that's because of effort and follow through, sometimes not.
Yeah,
Do you have
it's a
comments about
great
that?
point. And that's why we want to continue to optimize things, continue to understand this better. I want to make sure that people understand this is the beginning. This sort of thing has never been done before. And we've just been reporting the first reversals since 2014. So this is a relatively new thing. And I do want to mention your mentor, Dr. Mark Hyman, reported in his book back in 2007.
Yeah.
Ultramind solution, some people who reverse their decline as well. So this is a relatively new phenomenon, and we need to understand it better. The science helps the clinical part, the cases help the trial help the cases. So all these things working in concert really help to make this better, 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 better. And we're learning new things from this trial. So when you say get better, yes, some people got a little better, some people got a lot better. But again, in the other trials, people didn't get better. They simply slowed their decline. And that's a fundamental difference. We want to get people to prove. Now, we have seen people go from 18 to a perfect 30. And as an example, at one of the sites, every one of the treated patients came back to normal testing, except one who turned out to have a lot of mycotoxins, and she's still getting better. So there are people who get less better and people who get more better. And one of the things that we're trying to understand is why. Why do some of them do so well and some of them do not as well?
So let's maybe talk about that for a little while. Over the last many years, anybody that's followed your work probably was fascinated by this idea of metabolic subtyping.
Yeah.
And there's an inflammatory kind, you sort of had this inflammatory kind, people that are more.
Right.
So I don't know if you want to run through those and sort of say, for those that had familiarized themselves or read your 2017 New York Times bestseller, it was The End of Alzheimer's, which
Yeah.
was how our owner found you, actually, Kemper, our CEO, Kristen Kemper. She read that book and immediately contacted you. But has your thinking evolved? You want to lay out that metabolic subtype and then sort of say how over the last few years, especially since you've been doing clinical trials, how that thinking has evolved?
Yeah, it's a great point. So what I first noticed when I was looking way back in 2011, 2012, I was looking at the biochemical parameters for the various people with cognitive decline, and it was very clear that some of them it was mostly about inflammation. So I called that type 1 or inflammatory Alzheimer's. Other ones, they were completely different. They had no inflammation. In fact, if anything, they were low. They were more atrophic. So they had very low hormones and low vitamin D and low B12 and things like that. So I called that type 2 atrophic. And then there's glycotoxic, which is in the middle. I called that type 1.5 because it has elements of both. The insulin resistance component gives you an atrophic effect because you're not getting the insulin signaling that you should. And by the way, amyloid beta interacts with the insulin receptor and inhibits its signaling. So that's part of the whole story. And on the other hand, you have the high hemoglobin A1C, which drives some inflammation. You have glycated, non-enzymatically glycated proteins like hemoglobin, and that drives an inflammatory component. So that's type 1.5. Type 3 then is toxic. And as I mentioned, the three different types of toxins. Type 4 is vascular, and type 5 is traumatic. Any of these things can dominate. But as you know, these are often you'll have a mixed, you'll have some from type 1 and some from type 2, so that these things unfortunately collude to give you the cognitive decline. Now, where things have evolved is that we go back to the lab and look at, so okay, how does this all work together? And as I mentioned, the dominant three issues are energetics, all the things that make that up, inflammation, and toxicity. So now we look at more, where is this coming from? And it's important because if you've got someone where the main problem is energetic and there's very little toxicity, and you put them on detox, they're not going to get the same response as someone where it's mainly about toxicity. So I think, we're getting better and better at looking at what should be prioritized. If we're going to be able to bring this to everybody, then it needs to be something that is a little easier to do. You are an expert in this now, as are your colleagues who were in this trial, but it's not as easy as we would hope. On the other hand, if we try to make it too simple, we don't get positive results. So we've got to find a way to make it as simple as possible, but still get the best outcomes.
Yeah, absolutely. Okay, so we got a lot of detailed questions coming in, but I think we still have to keep it at the high level. I think you went through seven basics: diet, exercise, sleep, stress, and then you
Brain
mentioned
training.
detox targets, and then specific and then you mentioned infections. I think, did you meet one more specific? Sort of the second specific?
No. So the seven ones end with the targeted, so it's
Nutrition.
brain stimulation, basically, detox and targeted supplements. That's number seven. Then the two specifics are, do you have an infection? And if so, what is it? And how do we get rid of it? And we should spend just 15 seconds on that issue. As
Yeah.
you know, in fact, I think you were the one who made me aware of this. There was that interesting trial where they said, well, everyone keeps trying to do these monotherapies and just let's try one thing, where they just used valacyclovir and they actually saw that people got worse on that as a lone treatment. Okay, that probably engendered some inflammation and that sort of thing. You're now trying to get rid of infection. So maybe that's what it was. But for whatever reason, this is a concert. You can't say, oh, what if we just try playing the piano? Will that make the concert? It's not going to sound like an orchestra. You got to get all the things together to get things to work right. And it does involve treating infections. And the other specific one, as I said, is the toxins. So those are the two specific groups.
Okay. Can we talk a little bit about specifics about, like, a lot of people were going to ask about hormones, have asked about hormones
Yeah.
as a specific. You mentioned it. Did everybody in the study give hormones? I could tell you at our site, all the women got all the women got estrogen, progesterone. Many people
Mhm.
got DHEA, pregnenolone. I don't think we had any men that needed testosterone, but that's certainly and sometimes women with testosterone. Do you want to just spend a minute talking about hormones and their sort of place in your thinking?
Yeah, and this is an area of great controversy, as you know, because people say, well, we don't want to give postmenopausal women hormones. Well, anyone who deals with cognitive decline will tell you they do better with their cognition when they have optimal hormones. And of course, this was an area in the past where people thought, well, this may be the treatment for Alzheimer's. Again, as a monotherapy, it didn't prove to be very helpful. But as part of the overall protocol, it's very good. And we have real experts like Dr. Anne Hathaway, who was one of the sites for the trial, who has really spent her career looking at, do these hormones, are they helpful? All the ins and outs, all the concerns about them. And she will tell you that if you look at all the data, and of course, it's not all pro or all con, it's some of both. But overall, in general, people with the overall protocol will do better if they have optimal hormones, not surprisingly. And that, as you alluded to, is both men and women. And yes, the majority of people in this trial ended up having their hormones optimized in one way or another. Some of them, as you said, pregnenolone, DHEA, testosterone, basically what is needed. And of course, thyroid is another common one. People who have hypothyroidism will also have some issues. people who have hypovitaminosis D, for example, or B12. And of course, in the past, the idea was, oh, that means it has nothing to do with Alzheimer's. This is now a different disease. But in fact, it's all part of the same thing. This is part of the support of the network. And what's interesting to me is your brain is responding to all these different insults, whether it's nutrient deficiency or whether it's infections or whether it's other, by secreting this amyloid, by making this, which has turned out to be something that is remarkably good at sequestering pathogens, inactivating pathogens. And in fact, you have a period where you can have this in your brain for 20 years and have very good cognition as long as you don't start having a lot of inflammation. It's the inflammatory component that tends to take things downhill. So our belief now is that these amyloids, these prions, essentially, these things that are sequestering these pathogens, are actually pre-inflammatory immune mediators. In other words, they're part of the immune system, but they are a pre-inflammatory component so that you can literally get years of very good function before you have compromised function. However, if you now start bringing in the microglia and secreting the cytokines and you create an inflammatory situation, now you're starting to lose synaptic efficacy.
Yeah. Okay. These are interesting points. They're subtle. All the details of, when to start and who to start, and what about if somebody had cancer, breast cancer. There's a
Yeah.
lot of tricky, sticky wickets kind of through this whole thing.
Yeah, and you want to see someone who knows what they're doing when it comes to BHRT.
Yeah, BHRT is bioidentical hormone replacement therapy, for those who don't know.
Yeah.
Okay, so you mentioned, is there anything that you thought before Evanthea you didn't know, and now you know, like anything fundamentally new that you learned through the trial?
Oh, absolutely. And we're still learning new things. So one of the things we thought that the 6 sites would be fairly similar in their outcomes. And as you know, 4 of the sites, including Kemper, got spectacular outcomes with marked improvements, and 2 of them did not. So it really does. It's is very much, I keep seeing this again and again. This is much more like learning a new surgical technique than it is like prescription pad medicine. You have to do the right things in the right way at the right time with the right team. And so that really was driven home by seeing the results at site 1 versus site 2, 3, 4, 5, 6. Then the second thing is that one of the sites, as you know, Dr. Tanio down in Florida, did something where he did the basics for 6 months, and then he added some additional forms of stimulation between 6 and 9 months, and he got an additional bump. So again, we're learning, okay, maybe that's a good idea. We're looking at now, this maybe should not be just a one-phase approach. Maybe we should be taking this in a couple of different phases. I've often thought, is this something we're going to end up with doing things, including a little GLP-1 at the beginning, and then including a little microdose of anti-amyloid antibodies at the end to help slowly flush that out? We'll see. But the approach has always been a monophasic approach. And maybe we should be thinking much more in terms of biphasic or triphasic or multiphasic approaches. And again, the goal is always the same thing. How do we get the best outcomes, and how do we sustain them for the longest period of time? The great news is we have people who have sustained their improvement since 2012 now. So they're coming up on 14 years of sustained improvement, which, as you know, is unheard of in connective decline.
I think we might have one of your, Sally W. She thinks she's on here. She's connected to one of her.
Sally is 8 years into this now, and she's a great role model for so many people. And she is part of the survivors support group. And I attended one of their meetings a few months ago. And what was interesting to me is I realized after talking to the various ones, they're all the same. They're all like, get it done. I'm going to do this. I'm on it, And so definitely doing it, living it, as Sally has been doing, as Julie G has been doing, as Judy has been doing, as Deborah has been doing, as Edward has been doing, as Frank has been doing. All these people that were started years ago, they keep optimizing. And Sally herself will tell you she had some setbacks when things weren't addressed. In her case, as an example, She had a time when she had a roof leak and some new mold exposure, new mycotoxins, and it really did. She noticed the difference. It hit her, it changed her scores, it changed her symptoms. She found it, she addressed it, and she's doing better.
Yeah, absolutely. Okay, so this is a really and maybe to me it's maybe one of the critical things, and uh, our answer to this at Kemper has really been like, how do people stick with it, right? So one of the
Yeah.
participants in the study, we asked them for their questions. Thank you, Jan. Any advice on how to keep up with all the changes and sort of stay in the zone? You mentioned a survivor support group. We have something here we call Brain Masters, which is basically a peer support and coaching group. Like every day, I got to get up and get focused on this every single day. Any,
Yeah.
like, what are you seeing in terms of the people that are able to stick with it for 5, 8+ years? What are the
Yeah. It's a great point. So the first thing I would say is start with the fact that this is the first generation in history where there's been something to do. Marcus Aurelius wrote about dementia with aging way, way back when in Rome. And this is the first generation that's really been able to do something about it. We really should be able to make this and other neurodegenerative diseases the rare diseases that they should be by bringing physiology to what has been pathology. So that's the first thing, is just to feel blessed because you're in a situation where there was nothing before. The second thing is take it at your own speed. This is not an acute pneumonia. This is something that by the time you even get symptoms, you've had underlying pathophysiology for years, sometimes 10 or even 20 years. And that's been well documented with serial PET scans and serial spinal fluid analyses, things like that. So take it at your own speed, work with a good team that's gotten results. Ask them, hey, can you have me talk to someone that's gotten good results, or can you show us some of your data? Or best case, show us one of your publications. So that work with them just take it. And Sally is a great example. She's really kind of got this thing down. She really knows what she's doing now. She could teach a lot of people. I do think that people like Sally and Julie could help a lot of people by telling them, here's what it takes to stay with it and just keep doing it. Now, as you alluded to earlier, there are some people where you started and they're not getting better. And we're still trying to understand that. We're trying to study the ones who've done the best and the ones who've done the least. And let's see what's going on here. Let's see what the difference, what makes the difference. To some extent, what we're seeing is what makes the difference is doing the protocol and continuing to optimize those different pieces. So it is, there's a network and you've got to support that network. And then beyond that, I think, you know, it's like anything else. When you get good at it, and it kind of gives you positive feedback. I feel better. I'm thinking
yeah,
better. I
so
have
positive
better
momentum.
energy, and so that gives you the incentive to continue in the same way. I do think the hard ones are the ones where you're doing it for 6 months and things are not getting better. And my argument would be, yes, stick with it because you haven't hit that rate limiting step. Something is rate limiting here that we haven't hit yet. And so, we got to get that. And so I was on with someone today where they're trying to get things together. Things have continued to decline slowly, but they have continued to decline. Okay. It turns out this group, this person has some significant continued toxins. Okay, let's keep detoxing. Let's keep getting at this and getting things turned around. But I do think one of the things that helps is talking to others, support groups. And of
Yeah.
course, Dean Ornish has talked about this for years, so how helpful support groups are. You mentioned Kat Toops. She did support groups for the first trial and the second trial, this recent one. And the support groups do seem to help. People share and they talk about, hey, this is what worked for me, and they help each other through the tough times and looking for the right things. We're all still kind of building the plane as we're flying it. We're trying to understand how do we get better and better outcomes. The great news now is we have hundreds and hundreds and hundreds of examples of good outcomes.
Absolutely. This is a great point. So I think that there's another side, like another participant, like study, one of our Evanthea participants asked, um, when is the ideal time to start treatment? And then the other side of that is, and this is where you and I may have I don't know if it's a difference of opinion, but we probably just with, working at Kemper where we do see people at these sort of
Right.
later stages of dementia. Like, so this is the NIAs, as you know, Dale, I've just explained to everybody else. They've seen this a million times. There's sort of like a normal course of aging in the dark line, and then there's the dotted line, which is sort of the approximate trajectory of dementia you mentioned could be 10 years, 15, 30 years, whatever it is.
Yeah.
Most of the people in the Evanthea trial were at the stage probably where that green dot is, maybe a little bit further to the right, somewhere around there. Would you?
Yeah. Yeah. It's a great point. And this question of when do you start? That is really a personal decision, but it's important to say, well, what are the outcomes I can expect? So let's go backwards. If you start with a MoCA score of 0, which we have a number of people with MoCA scores
So
of
MoCA
0,
score is a just a paper and pencil test. Out of 30, best you can do. 0 is the worst you could do.
right? So you missed everything, and this is end stage dementia. We do have people who show some improvements, but they don't get all the way back to normal. We're still trying to understand research wise, what does it take to go from 0 to 30? We've seen people go from 0 to 9. That doesn't sound like a lot, but they're able to dress themselves again and speak again and take care of themselves, all sorts of wonderful things with just that. So it's harder when you do that. Now, let's move it back from the dementia side to the MCI side, which was this trial, MCI and early dementia. Not everybody got better, but the majority of people, if you do the right thing. But again, this was now 6 real experts, like Dr. Bergman, really going after it and really working with you. If it's out in the clinics, it's more like 50% of people are getting better. So again, I would like to start before MCI. To me, the sweet spot is the first 2 phases. So the first 2 phases are asymptomatic. So for a while, you don't even have any symptoms, and SCI. If you take the asymptomatic people who get on prevention, and I recommend anyone who's 35 or over, because we know that the pathophysiology, and this has been well documented now, can begin this is hard to believe, but they've shown changes in the late teens and early 20s. So this is again, just like we're seeing people with childhood obesity, childhood type 2 diabetes, things that we didn't expect before. We now understand that you can have the very beginnings. Now, it's just the beginnings, to be fair. Don't worry about it, but it's just the beginnings. So by the time you get to 35 or 40, it's a great idea to get your p-tau 217 checked, see what you stand. Now, there's been pushback there saying that only works for people who are symptomatic. No, a paper came out just recently showing that you can actually see people who are asymptomatic. It still is a very good predictor of whether you are making that amyloid response.
Okay.
So that's what I think is good. If you start at the prevention side and you do the right things, we've never documented a case of someone developing dementia. So it's a
Okay.
whatever
Dale,
it.
a bunch of questions. You just mentioned p-tau 217. Can you kind of go
Yes, we'll talk
through,
about
okay,
yes.
let's talk about biomarkers for
Okay.
neurodegenerative disease and your thoughts on when. So you mentioned p-tau, you've mentioned amyloid.
Yeah.
Can you just kind of go through the 4 ones we
Yeah.
did in the
And let me
trial?
just finish up with the last piece of SCI. So after pre-symptomatic SCI, subjective cognitive impairment, what that means is you know there's something wrong, but you're still able to score within the normal range on cognitive tests by definition. So it's what they're saying here, early symptoms. That is so-called SCI. You're still able to score normally, even though it may not be as well as you scored 5 years ago. Virtually 100% of those people, when we treat them correctly, do just fine. And so that's the sweet spot, prevention or SCI. All right, now p-tau 217. So there's been, again, we are very fortunate. There's never been a way to look inside the brain from the blood before. You had to have a PET scan, or you had to have an MRI, or you had to have a spinal tap. And I did, hundreds of spinal taps when I was training many, many years ago. It was a standard thing we did every day. I don't want to go and have a spinal tap every year. So the good news is I can now go get blood tests. I mean, I'm now in my mid 70s. I can go get blood tests, and I just did one a couple of months ago. Check my own p-tau, GFAP, and NFL. And so what that does is p-tau is a very interesting molecule. P-tau 217 is a site where it's phosphorylated. So what tau is, Tau is like a bolt. If you're adding on to your house and you got to make it stable, you got to bolt down. So in a neuron, you're putting out your fingers, you're making connections, and that takes your microtubules, and then the bolts that bolt down your microtubules are tau. Well, tau has two jobs, and actually several jobs. So its day job is to bolt this down. When you switch from that connection over to protection, everything changes. Now you're calling out the cavalry. You're saying, uh-oh, things are bad. We're going to fight something. So what happens is the tau becomes phosphorylated. What that means is you put phosphorus, the atom, literally phosphorus and oxygen together onto that tau. It changes the charge and it changes the shape of the tau. It pops off, and now the neurites can drop back. So you now can pull back, and it now goes off as an antimicrobial protein. It literally goes, finds microbes, and kills them. That's p-tau. So when you're testing that p-tau 217, the more of that you have, the more it's telling you you're on that protection side, not on the connection side.
A
And
simple point, these are tests are available through Neurocode, LabCorp, Quest. We do them through mostly, all those three we've done.
multiple places, right? And the thing I would emphasize to everybody, please don't worry about it. So I get frequent calls and emails. I found out my p-tau is high, thing's over. No, don't worry about it. We see them again and again and again coming down. Now, we did learn another thing in this trial, as you well know. When you do the right things and you lose weight and get in good shape, you'll get a bump, at least a short-term bump in your p-tau. So it doesn't come down as quickly as you'd like. But over time, stick with it. And we do see people, I see it again and again and again with people slowly coming down over time as they are doing the right things.
Would you agree that I probably at this point I'm sort of saying do it fasting, do it the same time that Kat sent us that paper, diurnal rhythms, and
Yeah.
so probably first thing in the morning, fasting. You would agree with these. Okay, so can we do a little bit
Absolutely.
more on the biomarkers, other
Let's do
biomarkers that we use?
GFAP. Yeah, GFAP and NFL are two more. And then, of course, A beta 42 to 40 ratio is the fourth one. So GFAP is one that is coming not from the neurons themselves, but from the astrocytes that support them. So the astrocytes that are glial cells that are around your neurons, these things, as they get called into action, they grow and they make GFAP, glial fibrillary acidic protein. And this reflects activation, inflammation, and attempted repair. So when that goes up, now in the trial, we had a statistically significant reduction in GFAP, which did not occur in the control group. And by the way, the recent trial of GLP-1s, where they were hoping, GLP-1 should be a great way to treat cognitive decline, it didn't improve cognition at all. And in fact, it bumped the GFAP up. So for some reason, it was actually causing a little bit of inflammation in the brain. So GFAP is very complementary to the p-tau, which is very specific for Alzheimer's. Then the third one is NFL, neurofilament light. That is telling you, for any reason, do you have damage to neurons? Traffic accident, stroke, anything that can cause it. And it could be Alzheimer's, frontotemporal dementia. So that's if that one bumps up. And we didn't see much change in that particular one in the trial. There wasn't a lot of high NFL. There wasn't a lot of rapid brain damage. And then A beta 42 to 40 ratio, which was abnormal in all but two of the patients in the trial, reflects, again, changes with these inflammation that are typically associated with Alzheimer's disease. So those are the four biomarkers, and they give us the ability to look in the blood and see what's going on or infer what is going on in the brain.
Yeah, and I think there's some questions, does somebody have to you get through a doctor? I mean, there are ways I think that you can get it direct to consumer. Typically they're ordered by a doctor at this point.
Yes, you can do it either way. You can get it directly, you can get it through your doctor.
Okay. Can you just a minute? We have a brilliant Michael. You know who you are. You're out there. I think he's on. So Michael's brilliant, and he had many questions about kidney function. Can you just maybe have a caveat of he asked, do you agree that people with chronic kidney disease or abnormalities in their kidneys may have higher test results, false positives for things like homocysteine, p-tau, etc.?
Yes, that's a very good point. So people who have chronic kidney disease do have changes. And I should also mention, as we talked about earlier, it also is weight related. If you have someone who is heavier, they will have an artifactually low p-tau. And if you have someone then who loses weight, they will have an artifactually high p-tau for at least some period of time. When they're stable, then you'll be able to see, where they stand. But yes, chronic kidney disease is definitely one of the caveats. And that's listed when you get the test. There will be a little caveat there at the bottom that explains kidney disease and and weight and things like that.
Okay, couple maybe a little more rapid fiery kind of questions. Do you have any
Yeah.
do you have a specific we did ketogenic diet. Every single person in the trial went on a ketogenic diet. And we tried to get them in ketosis. Do you feel that there's a specific number to get to for ketosis, or do we have that level of information yet?
Great point. So the issue is when you go into, so we want you to be metabolically flexible. The brain uses two different things, glucose, ketones. That's all it can use for fuel. So it's just like a Prius. Now, for the majority of people who come in with cognitive decline, they've lost both. They are insulin resistant, they can't use glucose appropriately, and they're not able to make ketones. So we want to get back, we want to return your insulin sensitivity, and we want to return your ketone level, ultimately endogenous, but you can just start out with exogenous. And yes, we want you to get above 1.0 millimolar beta hydroxybutyrate. That's what's been shown to be required to get best outcomes. And of course, there's all sorts of publications on this. People like Stephen Kinane, a professor from Canada, who's done some very nice work showing that ketones are very helpful.
Absolutely. Okay. A question, another one from one of our study participants. Does traditional medicine recognize the data? Now, to be fair, this is not this particular trial. You've had other trials that have been published,
Yeah.
Kat and you and Anne and Deborah, and then Heather Sanderson had an independent trial. There was no control groups there. We're still working on the publication, but does traditional medicine recognize this data, and will they implement it, is the question.
They don't recognize it yet. We know we've still got to get this published in a peer-reviewed journal. That's going to be out in a few months. We look forward to that. That's going to be an important milestone. But medicine changes slowly, as I think many people are aware. You go back to what happened with scurvy. People understood scurvy at the beginning, what you could do about it in the 1600s, 1700s, 1800s, 1900s, but they never actually got the traditional medicine never said, "Oh, okay, this is what it's about. We can fix this," until the 1900s. So for hundreds of years, people died needlessly of scurvy, which is really sad. Medicine is slow to change. We all recognize this. And so it's going to take, repeated trials. It's going to take, others repeating this as well. But what we can do now is we have the ability to help people. So let's help as many as we can. And ultimately, mainstream medicine, where, Nate, you and I spent our whole career, I spent 50 years in mainstream medicine. And it was only seeing the laboratory results that told me mainstream medicine is doing the wrong things when it comes to neurodegeneration. So it'll take some time, but this will happen.
Yeah, absolutely. Okay. Um, just like, some newer things, right? You mentioned Dr. Tanio's site. I know he was doing hyperbaric oxygen. He had a collimated laser beam. A lot of us are working with light
Yep.
therapy. We have a cranial, electrical stimulation we're doing. Like, can you just sort of talk about some of the new things that maybe you saw more of us doing in the trial, whether it was not all the sites, was different sites doing
Yeah.
things?
Yeah.
What are some of the new things?
Yeah, so I think the key point here is people ask me all the time, should I be doing some new, someone said that putting a crystal on your forehead was really helpful, this sort of
Why
thing.
not?
And I say, well, what about the basics? And they say, we're not doing any of those. So so I just can't stress enough. Optimize the basics, please, please, because you're really looking at a change in a network. Get the network going in the right direction. Now, as you said, then what do you add? There are all sorts. The armamentarium is getting huge, which is great. The negative is a lot of it is expensive, which is really unfortunate. My hope in the long run is that Medicare will recognize, hey, we can really help a lot of people. Instead of spending $40,000 a year for a drug, we can spend maybe a quarter of that and do much, much better. And so, or even a fifth of that or a sixth of that, something like that. I think we know now we can do for far less, we can do far more. Now, what do you then add? Once you get the basics supported, what can you add? A lot. So stimulation. You mentioned there's magnetic stimulation. There's I think photobiomodulation may be the most promising of
Which
these.
is light. That's just light, people. That's,
Light, and then I would include in there the laser, of course. And as you mentioned, Dr. Craig Tanio is doing this a really nice job. Dr. Robert Hedaya, your friend and colleague, I just talked to him a couple days ago. He's having obviously very good results doing the same sort of thing. There's one thing that I like a lot, which is exercise with oxygen therapy, EWOT. Again, it's a way to get more blood flow and more oxygenation to the far reaches of your brain. Very helpful. Hyperbaric oxygen. And that's one of the things that Dr. Tanio did at his site. He added it after the 6 months and he got that additional bump, which was great to see. So that's another great one. And then there's a new column called MTX 100. I'm very excited about this. When it's out, I'm going to get it for myself. It is a basically blood scrubbing. We all have some exposure to toxicity, and we want to be able to address this. It's nice because unlike plasmapheresis, which is taking your plasma, which in and of itself is somewhat of an insult, this is giving it back to you, but now cleansed. So I think that looks really good. So many of us, that is a rate limiting issue. So that's another big one. Of course, there are all sorts of ongoing trials with stem cells, and I think we're gonna learn more and more over time. What are the ones that are working best? Are we talking about ADRCs? Are we talking about umbilically derived? What are we talking about? I'm talking about cell lines. There are multiple ways to do that, but there's promise, but there's also expense with stem cells. Many of these things. So the whole area of stimulation and then support and then cleansing, plasmapheresis. Of course, Dr. Haas and Dr. Haas is one of the ones, and Dr. Dobry Kiprov, colleague for 40 plus years, Dr. Kiprov is a world leader in this area. They're having good results. Again, I've not seen as good results with just doing one thing as I have with doing this precision medicine sort of approach, which Dr. Bergman and all the sites did. But again, as an adjunct to everything else, this looks very promising. And then there are some very promising, now that we understand the pathophysiology better, there's some very promising drug candidates. I'm very excited about one that we developed in the lab we're looking now to get this into a clinical trial. What it literally does is to negate the effect of ApoE4. So it wipes out the effect of ApoE4. So it's great for prevention. It's great for treatment. It's not yet clinically available. We need to get FDA approval for it. But I've looked at the data. The data are very, very nice. It's orally bioavailable, highly potent, brain penetrant. It checks all the boxes to be a superb drug and could help. There are 75 million Americans who have a single copy of ApoE4. And that increases your risk from 9% to 30% during your lifetime. There are 7 million who have two copies. They are homozygous for ApoE4, and that increases your risk to about 90%. So I look forward to the day when nobody with ApoE4 has to worry about this. So I think there are a lot of things, Nate, that are so promising going forward. This is an era where things are just exploding with new ideas. Of course, there's TB006 that is an anti-inflammatory that people have used. There are all sorts of approaches that people have taken.
Yeah. Okay. So just thank you for this. So we have 350 people on now and so of course the questions are humming. So um, uh, one of the things you asked me, Dale, was like, what was the biggest challenge for us? And
Yeah.
so we have another brilliant person who's asked a question who brings a family member of his to us who's ill. And he said, I noticed that the trial involved patients who were enthusiastic when enrolling, which means they understood their cognitive decline and were looking forward to improve, thus high level of compliance, right, with what we were asking them to do. What
Yep.
to do with patients who do not have this insight and aren't able to sort of follow through? That's a very real question that we deal with almost every day.
Yeah. It's a great question. This probably goes back to with the question that I was asking you before when I emailed you the other day to say, what was your biggest challenge? So this is where what we found again and again, and I've listed in some of the slides in the past, like, okay, what are the things that correlate with best outcomes? What are the ones that correlate with failure in outcomes? And one of them indeed is a support team, a spouse who's helping, who's not saying, oh, don't do this. Well, we've run into a lot of people where The person will say, I want to do this, I want to come in. And then the spouse will say, no, I don't recognize this as part of standard of care medicine, therefore you shouldn't do it, which is unfortunate. So you're right. It helps to have some degree of compliance. And that's true whether you're taking a statin drug or penicillin or whether you're doing a protocol like this. Compliance is important to get the best outcomes. However, please note the compliance doesn't have to be perfect. Virtually nobody can do everything 100% perfect. Maybe Sally and a few other people, but most people cannot do it 100%. So do what you can. There is an activation there you got to get over, just like what Dean Ornish found years ago with atherosclerosis. You get past a certain point and the atherosclerosis starts shrinking instead of growing. Same here. You get over that threshold, and now you're actually seeing people improve. So please work at it until then. But you're right. We cannot make people better who do not want to be better.
And just an interesting sort of fun fact for people, since they're keeping score and wanted about the trial, we sort of developed these internal tools to make sure people were doing at least a certain percent. We pre-agreed before we did the trial that people had to, with all the stuff, all the 7 basics that you mentioned, plus all the things that we have, they had to be doing 70% or more in aggregate of all the things,
Yeah.
right? To see if because not all of our patients or our participants in the study were doing everything, but they were doing enough of everything that seemed to make the difference.
Yeah. And maybe if I could add one thing, is one of the common pushbacks we get is, hey, how come it wasn't 1,000 people? And so here's the thing. This doesn't indicate that they know science. This indicates that they don't understand statistics. Statistics, the whole idea of giving you a p-value is to say how big was the effect. If you have a very tiny effect, you need 1,000 people to show a difference. In our case, we had such a big impact that we initially calculated it would be between 50 and 60. We ended up with 73. But that's the whole point of this, that the statistics will tell you whether there is a statistically significant difference between the two groups. And if it's a big difference, you don't need as many people. Now, of course, we would love to do one with 1,000. I'd happily start that tomorrow, but that will cost about $80 million. Which for drug trials, there's been over $1 billion on one drug now. One drug for a couple of trials has now exceeded $1 billion. But for things where we're not going to sell hundreds of billions of dollars of a drug, that's not going to work.
Okay. So I just have to sort of pick and choose a couple of these last questions as we wrap up. Are there differences in treatments and outcomes with various kinds of impairment? So frontal temporal dementia versus Alzheimer's versus maybe Parkinson's dementia.
Absolutely. And so with what we're talking about is Alzheimer's disease typically. Now, some of these people we had about half of these people that had normal p-taus, which means that they were either in early stages or could have had other things like vascular disease and things like that. The other ones clearly had high p-taus and they clearly had Alzheimer's disease. So that's what this was designed for, the pathophysiology of Alzheimer-related cognitive decline, which is the majority. It's about 60 to 65% of all people who are coming in with age-related cognitive decline. We have seen not in trials, but anecdotally, we've seen improvements with vascular dementia. We've seen improvements in Lewy body dementia. We do not have a lot of data on frontotemporal dementia. It's much less common. We have single cases. We've seen some wonderful results, and a good example, corticobasal degeneration. Dr. Craig Tanio, again, has a wonderful example, which is now freely available online as a preprint. You can see this reversal of cognitive decline in someone with corticobasal degeneration. I'm working currently on a system for detecting Parkinson's early and preventing the motor symptoms, the things that actually that actually compromise your life, because virtually everyone with Parkinson's will present with things early, such as REM behavioral disturbance, which is flinging your arms around while you're sleeping, or writing getting smaller, or constipation, or loss of sense of smell. So we can pick these things up early. So again, we can do Lewy body, we can do things for a lot, but there are things we don't yet have enough data on. And a good example is frontotemporal dementia.
Okay, one point I really want to thank you for that, Dale. Just again, we're racing. We're just about up against the national championship here. So have you seen any results from folks doing the basics plus something like donanemab It can be because I'm very interested in this question. I'm not an either or kind of a person, so we have a few people doing this now.
Absolutely. Best outcomes is the only way. So again, let's go back to the theory. The theory is you should do everything else, get the network going in the right direction, support it, and then slowly bring in the antibodies. The problem with the antibodies is they try to do as a monotherapy. They try to do it too early before addressing the issues, and they try to do it with massive doses because they're trying to rip out that amyloid. When you rip the amyloid out, you bleed. So this stuff is in your vessels. So my argument is, look, it makes a lot more sense. Get going on the trial and then slowly bring this in, almost a micro dosing or low dosing of these antibodies. That actually makes a lot more sense. And I do think that they'll have a role in treating this disease.
Okay, and I know, so we're right at 7:30. I want to I want to be respectful of everybody's time.
Yeah.
I want to thank you most of all, Dale, for just the leadership, taking all the bullets, like we mentioned before,
Yeah.
just all the work, the dedication. This has not been easy. You could have a lot of easier professional pathways for yourself and all that you've accomplished so far. And so this is like we really are thankful. I would be remiss to tell our audience that like if you still have questions, we can try to answer some of those questions in future. All of the things that Dr. Bredesen just talked about, um, like how to get organized, how to move forward, and how to stay inspired is stuff that, like actually we started this Brain Masters group. This is the peer support and coaching group that we talked about. That for me, this was like a big light bulb moment a couple of years ago when we started the trial. This is what people need. So we have a
Yeah.
couple of our own sort of people surviving with Alzheimer's that are kind of at the helm leading this. So that's fantastic. And then we can talk more at a live event in about a month. So again, you could see our website for details for that. Any final questions or any final comments from you, Dr. Bredesen, before we go watch Indiana beat to Miami?
Yeah, so just two quick things. One is I'm happy to come back anytime and answer questions. Just let me know when. Always happy to support. I love what the work you're doing there. Love what the work that Kemper's doing is fantastic. And then the other thing I would say is we have to think, about things different. Let's all work together to reduce the global burden of dementia. We have the tools to do that now. There's no reason for this to be as common as it is.
Absolutely. I mean, and I'm going to apologize to everybody whose questions we didn't get to. But again, many, many thanks to Dr. Bredesen. Val, do you have some final things?
Just wanted to mention that we are planning to have a follow-up session. So I have the questions that were not answered. So we will be getting to those as well. So we'll keep you updated with that.
Sounds
Okay.
great.
Thank
All
you
right.
both.
Thank you very much.
Yes.
Thank you all.
Thank
Best day.
you.
I'll be in touch. Okay. Thank you. Good night.
Bye-bye.